100 years ago, infective endocarditis used to be a death sentence. Today, survival has improved since, but in-hospital mortality is still around 20%, which is high despite advancement in treatment. There have been three key historical developments that have improved treatment and prognosis in this otherwise deadly disease. Stay tuned till the end to find out what I think these developments are. My name is Dr. Hafez Nadiri and I'm a cardiology trainee in London, currently undertaking a PhD. Welcome if you are new to the channel. Here I speak about heart health and topics relating to cardiology. In this video I'm going to talk about infective endocarditis. I think this is a really important condition to be aware of, regardless of your specialty, as it can present in many different ways. From my experience, cardiologists usually get cases of endocarditis referred from other specialties, so it's worth knowing about. So, what is endocarditis? Well, endocarditis is inflammation of the inner lining of the heart. The heart wall has three layers: the endocardium, which is the innermost layer covering the heart chambers and valves, the myocardium, which is a muscular layer, and the epicardium, which is a protective outer layer. Infective endocarditis is usually caused by bacteria entering the bloodstream. So how does the bacteria get into the blood? This can happen as a result of everyday activities like brushing your teeth, particularly if there is poor dental health, or during dental procedures where there is a transient bacteremia. This means there is a sudden surge of bacteria in the blood. Other ways microbes can get in is via an open wound in your skin, infection in any other organ system in your body, or via introducing a contaminated foreign object in the body, such as a central line, for example. For endocarditis to occur, there has to be damage to the endocardium. Any areas of the heart which is exposed to turbulent blood flow can be damaged, so abnormal valves or septal defects. The turbulent blood flow damages the endocardium and exposes the underlying collagen and tissue factor. This can allow bacteria to attach and colonize to that area of damaged endocardium. A healthy heart is usually resistant to infection. This is because bacteria cannot adhere to the surface of an intact endocardium, and the constant flow of blood also prevents bacterial attachment, and the bacteria that do get in are usually destroyed by the immune system before they start to cause a problem. But certain people are more prone to getting endocarditis. The risk factors for endocarditis is anything that can disrupt the endocardial layer. These are things like previous valve surgery or other implantable heart devices, congenital heart disease, heart valve disease, or if you've had endocarditis before. Now, what are the symptoms of endocarditis? The symptoms of endocarditis can develop slowly over time, so it can be insidious in onset, or sometimes they can start suddenly, what we call acute. So common symptoms are fevers, sometimes night sweats, feeling fatigued, achy, and unexplained weight loss. Important to know that endocarditis is not contagious. It's a rare condition, but we worry about it because it has a high mortality rate. So why the high mortality rate? There are three main complications of an infective endocarditis. The first being heart failure. Second being uncontrolled sepsis, usually as a result of abscess formation. And thirdly, embolic events where the vegetation dislodges and travels elsewhere in the body, affecting other important organs. If the vegetation is in the right side of the heart, it will travel to the lungs and potentially cause an infarction similar to a pulmonary embolus. And if it's in the left side, it can travel to the brain, the kidneys, and the spleen. The family of bacteria which is usually responsible is Staphylococcus or Streptococcus. 25% of cases of Staph aureus bacteremia have infective endocarditis. These are organisms usually found in the skin. So if it's seen in blood cultures, then there should be a low index of suspicion to do imaging of the heart if no other source has been found, particularly in the context of clinical signs such as a new murmur, for example. Staph also has a worse prognosis and higher risk of systemic emboli. Other causative organisms are strep viridans, which is bacteria found in the mouth. Less common organisms are Haemophilus and fungal endocarditis, which is more common in immunocompromised individuals. The key to treatment is to identify the causative organism. So blood cultures are key to identify the causative microbe and therefore administer the appropriate treatment targeted to that particular microbe. Antibiotic therapy is usually for weeks, and key to treatment is also to remove any potential source of infection. And of course, appropriate imaging, usually with echocardiography and relevant scans of the brain and rest of the body where clinically indicated. For example, an MRI or CT head for those with neurological signs. And surgery for cases requiring valve replacement or repair. There is now a multidisciplinary team approach to endocarditis management. These endocarditis teams consist of cardiologists, infection disease experts, and surgeons who can look at each case in detail and decide together for the best approach, which has been shown to make a positive difference to patient outcomes. So at the start of the video, I spoke about how survival of endocarditis has improved over a century, and I alluded to 3 developments. The first is better imaging diagnostics, in particular echocardiography. With echocardiography, we can now see infection of the heart clearly and in real time. It has allowed us to assess valvular endocarditis and its complications. Other imaging modalities such as PET has also been helpful, particularly in cases of endocarditis of replacement valves, which can sometimes be challenging to decipher on echo. The second important progress was treatment, and in particular the discovery of penicillin. In 1928, at St Mary's Hospital in London, Alexander Fleming discovered penicillin. And as most cases of endocarditis are due to bacteria, penicillin has completely changed the landscape. And finally, advancement in surgical techniques has also had a huge impact on improving survival of patients with endocarditis. So we've come a long way, but infective endocarditis is a diagnosis not to miss. So I hope that was helpful as an overview of infective endocarditis and how it's changed in terms of prognosis in the last 100 years. Thank you for listening, and I'll see you in the next video.